They're just like the Nita one, but like I think like a different texture. They're minions. Yeah. Oh, let me.
Oh, I'm talking and I'm not muted. I mean, I was muted. Hello. I'm going to cut my camera off real quick and give everybody a minute or two to get in, and then I'll hop on and we'll get started. All right, I think I let everybody in. Let me see. Teams is not my favorite. Okay, I think everybody's here. So how y'all doing?
Good.
Who said that?
Morgan.
Morgan's doing good.
Doing
Nobody
good.
else?
Yeah.
We're good.
I'm
We're
good.
good. Good. How are you?
Good.
Are y'all feeling accelerated these days?
Oh yeah.
Yes.
Ooh.
Very.
Turbo
This is
speed.
yes. Honestly, I heard y'all did well for the most part on your adult health exam, so congratulations. That is usually a very difficult exam. And I'm sure there are lots of different reasons why that was the case. And so I'm glad that that turned out the way most of I wanted to. So we were very proud of y'all and glad of that. And that's one down. So thank God for that. I intend on us going through, I have about 100 things pulled up here. So I was going to try to um, go through a review that first is going to just talk us through some things. Several of you mentioned wanting to meet and just be able to discuss. So I figured that I would go over things that are commonly missed or stuff that maybe I feel like I didn't cover good enough or just want to make sure y'all understand and kind of talk you through it. And then we'll see how we feel after that. I don't know exactly how long that's going to take. Um, and I also created some review questions. So if y'all decide y'all don't want to do the review questions, I'll kind of give y'all that option once we get there. I can provide those to you so you can go through them and see the answers yourself. But sometimes it's helpful, I think, talking through things because even if I tell you the right answer, doesn't necessarily mean that you get it or, in fact, I will tell you something that I don't know if this has been shared with you yet, but when I was in nursing school, I single-handedly can tell you the only thing that made me pass nursing school was NCLEX review book. It was called a Saunders. I think we make y'all get that book, so you should have access to it. And in the book, it has rationale. So it kind of does like a synopsis, a short little breakdown of the content. Instead of it being 37 pages you have to look at, it's 3 on cardiac, let's just say. And then at the end, there's questions. And after the questions, there's rationales for the right answers. And then there's rationales for the wrong answers. And I can tell you, there were so many times where I would answer questions and I would get them right. And then I'd read the rationale and I'm like, that is not why I got that right. And so I would encourage you to do that. I would encourage you to read rationales anytime that you get the opportunity for whether you got it right or wrong, because sometimes you just looked up and did get the right answer, but you really didn't understand the concept of it. And so if you had to, number one, do it, right? If you had to go apply that information, you're not going to be able to do that correctly because you didn't grasp the concept. Or if the question is presented differently, you're going to get it wrong. Okay. So, anyways, I'm saying all that to say that sometimes it is helpful to just talk through questions and why things are right and why they're wrong. All right, let me see if I can pull up this PowerPoint. And I'm going to try to record this also. Oh, I set it to automatically record. Great. We'll see if this will work. And I'm going to need y'all to respond. And I will tell you that even this isn't necessarily the question quiz part of it. But I am going to ask y'all a lot of questions. So it would help if y'all will interject, please, as I'm going through. Can everybody see the slides?
Yes.
Yes.
Okay,
Yes.
thank you.
Yes.
Okay, so moving to first, we're going to talk about insulin. So in this particular PowerPoint, this is more just insulin and some respiratory things because those are things that students just really struggle with. So I'm going to just believe that all of you have taken the time to watch all of the recordings that I have put on Canvas thus far. And so all of this should be a review. If you haven't, I encourage you to do that ASAP because again, you are responsible for knowing that information and it's just going to get you further and further behind. And you have a test coming up on endocrine and respiratory for adult health too. So this is information that you need to know. I mean, adult health one, excuse me. Okay. So as I said in the recording, there are different types of insulin. So first of all, what is insulin?
Insulin allows oh, mute your thing, Zach. Oh my goodness.
It's like a hormone produced by the pancreas that like pulls the glucose inside the cell essentially.
Perfect. So it gets sugar out of my bloodstream, right? Into the cells in order for my cells to function as they need. Most importantly, brain cells, right? They are essential for function. So, before I give, thank you for the attempt, Morgan. So before I can give insulin, what do I need to know?
The blood sugar.
Very good. Especially what's going to help me decide, or what's normal blood sugar?
Less than 100.
Okay, so is 2 normal?
70 to 99.
100.
70 to 100, yeah.
There we go. So, and I wasn't being a smart aleck. It is important to know, right? Because you can also be too low. In fact, would you rather be too high or too low?
Too high, because too low can kill you.
That's right. So too high could also, but it's going to take me longer to get there, right? Too low, it might be too hard for me to come back from. Okay. So, I need to know what the blood sugar is. And I also need to know what type of insulin I'm given, right? Because that's going to matter more depending on the onset, peak, and duration of the insulin that I'm administering. So, so when you, so sorry. I'm trying to think of how I want to ask this. So, is there, what else might you want to know? I guess maybe the other question that I would want to ask. How do I know it's safe to give it?
The peak times, but I don't know anything about that, so I was hoping you could tell us about that.
Well, I did tell you in the lecture that I recorded.
Oh my God, I haven't watched it yet. I will.
So it also happens to be on this slide that tells you the onset is indicated on this slide of when these things are going to go into effect. So let's say you have different categorizations of insulin. So there's rapid acting, there's regular, or why can I not think of that? Short acting, and then intermediate, which is your MPH, and then Lantus is one of the long acting. Okay. So if something is short acting or rapid acting, and I've already said that when I give you insulin, it's going to take sugar from your bloodstream and put it into your cells. And I said I'm going to check the blood sugar before I give it to you. What do you think it would be important for me to know, or I would be worried about with giving insulin?
That patient has access to food if it's immediate, that there's food
Very,
available.
very good, because it's going to make their blood sugar do what?
Go down.
Drop. It's going to drop. And
Drop, yeah.
that's what I want to happen. I want it to drop. That's why I'm giving it to them. But if it drops too much, then they can get hypoglycemic. And we already said if that gets too bad, they can die, right? So that would be very important for me to know if they have food. And that's going to matter more if the patient or if it is a rapid acting insulin, okay? Because it's going to immediately, like this Lispro, within 15 or 30 minutes, that insulin is going to take effect. The regular is a little bit longer, so I have a little bit longer to wait before I need to make sure they have food. The MPH, you can see it, that has a little bit longer. And then the Lantus, that takes so long to go into effect, but it has no peak. So the way that I describe long-acting insulin is most of the time the people that are taking that are type 1 diabetics. And I have to give them insulin in order for them to have it. So they are not going to have insulin. And so that long acting is really acting like what your body would normally just have. It's just giving them some. And then the short acting insulin, they will take that with meals or they'll check their blood sugar at meals. And it's kind of like they can take it if they need it. It's not necessarily, that's considered more like meal coverage. Yes, Emily.
So yesterday I had a patient with type 2 diabetes, and we
Mm-hmm.
gave both short acting and long acting at the same time. And he was sleeping, so he didn't have food. Is that normal to give both?
So what was his blood sugar?
344.
Okay. Do you think his blood sugar needed to go down?
Yes.
Yes, I do. Is there a concern, do you think, knowing, even if you know nothing more about insulin than what I've said and what's written on this slide, do you think it's more of a concern that you gave those two together, or if you were to just give the short acting?
Gave them together.
I don't know.
Anybody else?
I think
I
it's
think
more
if
of a
you give them,
concern.
yeah, okay, go ahead.
I just thought that it would be more of a concern if together, because like both of them are going to act at the same time, and you
Act.
need to take care of two peaks, the short acting peak
Mhm.
and the longer one, and the
So
mealtime needs to be separated.
read what it says under Lantis that's written on
It,
this slide.
it does not have a peak.
It doesn't. And it's going to take longer for it to kick in. And so it really is just a baseline. So that person, I would assume, that they have had uncontrolled diabetes for quite some time, which is how they've even progressed to needing long acting. So it really doesn't matter that you're giving both of those because they're not acting the same way. Now, a general rule, do you remember if you gave regular or Lispro?
It was Lantus and Lispro was what we gave him both, and he was 80, so yeah, I imagine he had for a long time.
Um, and really, I mean, people can have for a long time, just depending on how they control it, can make a difference. But it doesn't sound like he was taking his medication like he should, and or like diet and exercise like he should. Um, what I will say is one of the considerations when somebody's in the hospital, stress can make your blood sugar go up. And so you need more insulin. And so in that case, giving it to somebody sleeping, I probably wouldn't do that anyways because it's going to drop. But after you check it, what should you be doing? I mean, excuse me, after you give it, what should you be doing anyways?
Monitoring for hypoglycemia. He had
I'm
dementia,
monitoring.
so he was just kind of difficult anyway.
And it really, I mean, that is patient specific, and that's a great question because it sounds like I'm sitting here saying, don't give this unless you have food. And I would say most of the time, no. But also if their blood sugar is 344, I need to give them something, right?
Mm-hmm.
You just do need to monitor for hypoglycemia. And in that case, if like signs and symptoms might not be as evident, maybe what do you need to do?
Check his check his blood glucose.
His blood sugar. Yeah, just check it again. And I'm checking it based off of when I know this is going to go into effect. So when would I check it again?
Every hour, right?
During the
Not
peak.
every
Mm-mm.
hour.
You would check it during the peak.
Okay. Well, for this, I would say for onset, right? Because that's when it's going to start going into effect. Because it does not take it very long for Lispro, from the time it goes into effect to its peak is a very short time, right? And so I'd say if you're giving somebody Lispro and you're worried about that, I'm looking for signs and symptoms anywhere to 15 to 30 minutes after. Now, once somebody's taken this for a long time and you kind of know their routine and how they respond to it, that isn't something that you're going to be every single time you go give them insulin, you're going to recheck their blood sugar in 15 minutes. Instead, you're doing what you said first, which is you're monitoring for those signs of hypoglycemia. Because otherwise, if I told you at every meal, at bedtime, and just in the morning, I have to check your blood sugar, give you insulin, check it after, potentially give you more insulin, check it after, give you whatever, who's compliant with that? No, nobody would be, if that makes sense. Um, So long acting is usually once per day. Sometimes it's twice per day, depending. And then they may have a standard, like I'm betting what your patients was. Some patients have like their orders might say they get Lantus 20 units once a day. They get Lispro 2 units at meals and at bedtime. And then they may additionally have a sliding scale ordered. And that's just because their blood sugar is harder to control. So they're just giving them like baseline to begin with. And a lot of times, type 1 diabetics, that would be the case too, because they know that they're going to need coverage for those meals. But a lot of times type 1 diabetics also have I just lost my train of thought. Oh, like insulin pumps where they're able to control that more regularly. So before I move on from that, because I don't think I have anything about that in here, an insulin pump could continuously give a patient insulin, or it can give boluses or like extra doses based on if they select to do that. What do you think is important as a nurse to do if your patient has an insulin pump?
Make sure it's like set to the right setting so it's not over administrating.
Very good. What else?
That the patient can actually manage the pump, that they know how to use it, and it's.
That I've educated them, that I know that they can use it, especially if it's new. What else? What would you be worried about?
Hypoglycemia or hyperglycemia.
Yeah, making sure it's applied correctly. Is that what somebody said?
Yeah.
Okay, that's right.
I know that you also have to keep them dry, so making sure that they're clean and intact one, but just making sure that it's not getting wet somehow.
And
Very
change
good. And And I would say that's really important. And just a kind of a side note, because there's gonna be things that patients come to the hospital with, right? Such as an insulin pump. And it's not your responsibility or not something that you have to worry about just because they came in with it, right? You're still taking care of them and including that as part of them. What I was reaching for or searching for is if your patient has a procedure and they're NPO and they're constantly getting insulin, am I worried about that?
Yes.
I I am. And so I may have to get an order from a doctor to turn their pump off. And then we will monitor and administer insulin based off of the findings, basically, based off of how we would normally do that with another patient. When do you think I would hold insulin? If somebody just regular, let me ask that differently.
Like with
When would I
blood pressure?
hold Let me ask real quick and then I'll let you answer. So sorry. When would I hold if my patient just had a standing order to give Lispro 5 units before meals and at bedtime?
If their blood sugar was already low.
Okay, so if their blood sugar was less than 70, what else?
Um,
Would it be if they were NPO and couldn't eat anything?
If they can't eat, like if they have to go to surgery or if they have to go to a scan or if they have to go wherever, if they're not eating. And I'm going to correlate that with, because if they're not eating and their blood sugar is 300, I'm still going to give them insulin. Maybe not that as much as you would because they're not eating. That would be a conversation with the doctor, but it is going to be patient specific. But in general, if a patient is not eating and I'm telling you that they have to eat to get this insulin, I'm not giving it to them, regardless of why they're NPO. When else might I hold it? What about if your patient's throwing up? If my patient is vomiting, what do you think their blood sugar is going to do?
Go
when you
down?
drop,
It'll go down.
It'll go down. So am I going to give them insulin?
no,
No.
no,
No, because they're probably also not eating, right? And if
right.
they are, it's not doing them no good. So that would be a time. Now, what about Lantus? I said this is a baseline. There is no peak. This is just normal insulin I'm giving them. When would I hold that?
Mm.
What
Y'all are
about
allowed to be wrong as well.
like an allergic
when
reaction?
you got low blood, when you hypoglycemic,
When you
like
show
severely
symptoms of
hypoglycemic,
hypoglycemia, like
If they're
symptoms,
NPO
and
for
like,
an
like it's
extended
really low.
period of time,
Who
because I
said
thought
that?
you wouldn't
Karthik?
hold,
me,
like,
Karthik.
because I thought the sick day insulin rule was that you don't hold insulin when they're sick.
I'm
Mm.
asking you.
Because I read like that you don't hold insulin, especially the one that does not have a peak, because you don't want them to go into DKA when they're sick. Because when they're sick, their blood sugar rises automatically because of stress. But I don't know.
Okay, so you say no matter what, if they're sick, I'm giving long-acting insulin.
I I don't know. I just thought you wouldn't hold insulin if they're like, sick day protocol.
So somebody else said that we would hold it if they have hypoglycemic
Mm-hmm.
signs, right? What are
Yeah.
hypoglycemic signs?
cool, clammy skin, confusion, lethargy, you know.
That's
Okay.
it.
So let me ask this, and we're just talking. There's not right and wrong. If I go into my patient's room, or you go into your patient's room, and they're cool and clammy and lethargic and confused, but they're sick, do you think we need to give them Lantus?
Mhm. No, because there's no peak, right?
Would be their blood sugar.
I don't know.
Okay, we're gonna check their blood sugar. Number one, we want to know that their blood sugar's 50.
Mm.
I don't know, because if it's 50, probably not, but I don't know the whole protocol.
But it's not gonna peak.
Yeah, so
Yeah.
in my head, I'm like, I don't know if we should hold it.
What would help you make that decision?
if there's
Revival.
symptoms, like if they're asymptomatic or not, like how they feel. I don't know.
They're symptomatic.
Okay.
If
Karthik, say
So
what you
like
said again.
even
I said when they're NPO for an extended period of time.
So right now, their blood sugar's 50. They're cool, they're clammy, they're confused. What would I want to know?
What the doctor wants to do?
Hallelujah, sure. But for my own sake, what do I want to know?
if they're getting IV glucose or dextrose, if they have access